We are live now.
Uh, Good afternoon, everyone. I am Subhash from Dr. Reddy's. Today we have Dr. Deodatta Shripad with us. Doctor will give us valuable talk on diet in chronic kidney disease. Dr. Deodatta Shripad is a DM nephrologist. He is well-known nephrologist in Nashik and in entire Maharashtra. Doctor has his own setup in Nashik, that is Supreme Kidney Care. Doctor is also attached with Hokard Hospital, Sahyadri Hospital, Ashoka Medicover Hospital, and many well-known hospitals in Nashik. Over to you, sir.
Yeah, thank you, Subhash, for that introduction. And hello, viewers. I've been working in the field of nephrology since the last 35 years. And today we are going to discuss a very important topic which makes a very big difference as far as patient care and patient management is concerned. And it is related to nutrition. What kind of dietary precaution should be taken in patients with kidney disease or chronic kidney disease CKD? So it is something which is very, very important, and everyone should know what are the nuances of nutrition therapy in patients who have a kidney problem. Before we discuss about the diet in chronic kidney disease, we should know how do you define chronic kidney disease. It can be defined as a sustained damage to the kidneys, and this sustained damage should be for more than 3 months. And ultimately, this damage to the kidney, because of many reasons, can progress to what is called as chronic kidney disease, followed by end stage renal disease. So, when we say end stage renal disease, we mean that the kidneys are not working at all and the kidney function is down to less than 15% by way of estimation of what is called as GFR. And if this end stage renal disease is not treated on time, then naturally the patient is going to have many complications and ultimately patient may perish. So when we think of treatment for chronic kidney disease, diet therapy or dietetic nutritional therapy is a very important part of the treatment. All of us must consider nutrition therapy like a medicine. So just as a doctor prescribes medicines to his patients, in addition, the nutrition therapy should also be prescribed properly, and the patients also should follow the instructions regarding nutrition as well as take the nutrition therapy, whatever has been advised, so that you get ultimately a good result as far as the disease is concerned. And this dietary nutrition therapy has to be integrated or advised together with the pharmacological therapy or the medicines. And whenever we talk only about nutritional therapy, what is the objective? The objective is generally the same. The first objective is that the patient's nutritional status, as far as his body is concerned, should be optimized. That means it should be normalized as much as possible because it is disturbed because of the disturbances in the body due to the disease. Then, because of the disease, the patient will have so many physical symptoms, and the patient may have many other complications related to the chronic kidney disease. So, the second objective of dietary nutrition therapy is to reduce the symptoms of the patient by way of additional therapy with diet. And the third objective is to delay the start of dialysis. You know that dialysis is a therapy which is called as blood purification therapy, which is given to patients when kidneys are not working at all, and the work of the kidneys, which is blood purification primarily in the body, it is done by artificial means by way of hemodialysis. That is something which starts when the kidneys have failed completely. So, if you want to delay the start of dialysis, again, dietetic nutritional therapy would definitely help. If you give a proper nutritional therapy, then it might be possible for you to reduce the medications which the patient is taking, and it might be possible for you to delay the dialysis by maintaining the patient's kidney function for a slightly longer period of time. But fundamentally, if you want to have a successful result, then adherence of the patient to the dietary plan is very, very important. That means the patient should take the dietary advice very seriously and then try and follow it so that you can achieve all the objectives which we have mentioned previously and get a good, successful result. Now, dietary interventions are essential in patients with kidney disease, but the recommendation may vary depending on the type of patient, the cause of kidney disease, then what are the coexistent medications, what are the other treatment methods. For example, whether the patient is a diabetic or a non diabetic, whether the patient has got complications related to the disease or no complications, whether the patient has got moderate kidney failure or severe renal failure, etc. etc. Whenever we are considering dietary nutrition therapy, also we must remember that protein calorie malnutrition is a consequence of the disease, and that definitely affects the outcome as far as the patient is concerned. So, early diagnosis of protein calorie malnutrition and proper treatment of the same will also be very important if you want to get a good result. So these are the objectives of what is called as dietetic nutritional therapy in patients with chronic kidney disease. Whenever the kidney disease progresses over a period of time, the requirement of the body as far as essential nutrients are concerned, it keeps on changing over a period of time. Many vitamins they become deficient, many of the essential nutrients also become deficient, and you have to take care of all these aspects when you are advising dietary nutritional therapy. We have already talked about the problem of protein calorie malnutrition, which also needs to be addressed. The general nutritional principles are followed whenever we are treating patients with chronic kidney disease, and we shall discuss these principles of nutrition subsequently. Remember that the therapy has to be individualized, and it is not one glove fits all. Every patient is different, every patient's nutritional requirements are different, so therefore therapy has to be individualized so that over a period of time you get a good result. Also remember that there might be some associated issues also along with kidney disease. For example, a patient with kidney disease could be having a coexistent cardiovascular disease or coexistent high blood pressure. In those situations, again, your dietary advice will need to be modified so that the patient gets symptomatic relief as far as his problems are concerned and his comorbidities do not worsen over a period of time. Now, why should a patient of chronic kidney disease have a poor nutritional status? It is very easy to understand that why do they have this problem. So, first of all, there are losses of nutrients because of the disease itself. There could be increase in the energy expenditure. Older age is another issue. Many of these patients have severe anorexia, nausea, and vomiting. So, therefore, again, the nutrient intake goes down. Frequent hospitalization is another cause whereby nutrition is very poor. Presence of comorbidities, which I already mentioned, like diabetes and hypertension. The inadequate dialysis dose, that means if the patient has got uremia, that means very high urea creatinine levels because of whatever reason, again, that also induces a lot of malnutrition. There could be some other disorders which induce inflammation, and inflammation can also contribute to all these nutrition issues. If you are giving some medications like, say, NSAIDs or painkiller drugs, then if the patient is catabolic, that means the energy expenditure is more than the energy manufactured, and there are protein losses. All these factors are associated with a poor nutritional status. In addition, remember that the acid content in the blood in patients with chronic kidney disease goes up because the acid is not neutralized by the alkali, it is retained by the body, and therefore, this acid issue can also contribute to the nutritional status. So, when you are discussing nutritional therapy in patients with chronic kidney disease, we have to remember that so many coexistent factors are there which you will have to address in your therapy. So, which will include drug therapy, it will also include nutrition therapy. Once we have understood the importance of nutrition therapy in patients with chronic kidney disease, then the next question is how do you evaluate the patient's nutrition whenever the patient comes to you? So, the first point is that the patient should be referred to a nutritionist or a dietitian for initial evaluation, and there are some ways by which the nutritionist is going to do the nutritional assessment of this patient, which we will elaborate later. The history of the patient is not only the medical history important, but the social history, the background of the patient, cultural background, the personal habits of the patient, history of coexistent diseases and coexistent medications. All these things are very important whenever you are doing the nutritional assessment. Of course, the nutritional assessment will be incomplete if you don't have the biochemical data. That means you should have data regarding blood sugars, the renal function, serum electrolytes, calcium, phosphorus, uric acid, and so many other biochemical parameters, cholesterol. All these things should be considered whenever you are evaluating a patient for the nutrition assessment. Then the next step would be to look at the anthropometric measurements, which include the height, the weight, body mass index, waist circumference, and the change of weight over a period of time, whether the patient is losing weight or the patient is gaining weight over a period of time. So, all these parameters are also going to help you to decide what is the current nutritional status of the patient. Whenever you are looking at the nutrition history, then always ask for how much is the food intake, what is the physical activity, even if you advise food, whether it is available or no, the economic issues regarding nutrition therapy, and consideration of comorbid conditions. So, all these things are important when you are assessing the patient from history, and the next step would be, of course, physical examination. Now, physical examination can be done to find out whether there is nutritional deficiency evidence, objective evidence of nutritional deficiency, or whether there are any organ specific complications which can also be diagnosed on physical examination. So, suppose a patient has got chronic kidney disease and the patient has to be given a dietary therapy. Then remember that the important nutrients which we need to consider in a patient with CKD would be the caloric intake, the protein intake, carbohydrate intake, the lipid intake, as well as the phosphorus intake. These are important things in a patient with CKD who is not on dialysis. But if a patient is on dialysis, then in addition to the all the points which have already been mentioned, you also have to look at sodium, potassium, fluid intake, calcium, and phosphorus intake. So the dialysis patient could be having some extra requirements as far as the nutrients are concerned. Also, remember that the therapy can change individually depending on the size of the patient, the stage of CKD, what is the nutritional status of the patient, and what are the lab results. Remember that all these things are variable. For example, you can have a very tall and a thin individual, or a short and a fat individual. You can have a patient who has got stage 2 CKD or stage 5 CKD, or he could be on dialysis. There could be one patient who has got good nutritional status when he goes on dialysis, and there could be some patient who has got on laboratory examination hyperkalemia, hyponatremia, hyperparathyroidism, etc. etc. So, the individual differences also need to be considered whenever we are advising nutrition therapy. Then the diet goals, as far as a patient with CKD is concerned, are related to weight. That means optimize weight, attempt to get a good nutrition status, and of course, maintain your sugars and blood pressure. If a patient is on dialysis, then again, you also have to look at the fluid status, which is very important for patients on dialysis. So the message here is that taking into consideration the nutrient needs and all the other laboratory reports, physical examination, and the goals which could be different in different individuals, you have to individualize the nutrition therapy. The second step of assessment of nutritional status is to maintain a dietary diary. Now, for a patient, only verbal communication is not important. The patient has to actually maintain a diary and write down on a daily basis what is the exact intake of food, how much is the food, and then from that, you can calculate what is the intake of proteins, fats, carbohydrates, minerals, electrolytes, fluids, etc. etc. Similarly, there should be a system of dietary recall. The dietary recall, what should it do? Once you have advised the patient a particular dietary therapy, then you can do a recall after some time to find out whether this diet, whatever was advised, is being followed, or are there any mistakes in following this diet, or whether, in spite of following this diet, the goals have not been achieved. So, maintaining a dietary diary and dietary recall after giving advice is very important whenever you are advising a patient on nutrition. Subjective global assessment is a method or a tool by which we calculate the patient's nutritional status, and there are three patient reported components like weight loss, appetite, and vomiting. And there are three evaluator performed components, and is going to tell you this assessment is a sort of a pro forma which should be filled in every individual. Try and find out whether the patient is malnourished or undernourished, depending on the SGA score. And if the patient has got a poor SGA score, then you can reset your goals for optimization of nutritional therapy and achieve your targets as much as possible. So, SGA score really helps you to find out the current nutritional status, and after some time whether the patient has achieved whatever was to be achieved. Now, coming to the actual management. So, what we have done is we have looked at the need for nutritional therapy in patients with CKD. Then we have said, how do you assess the nutritional status of a patient? What are the parameters which we consider whenever we are advising on nutrition status. Then, how do you do the assessment based on physical examination and various indices? And now coming to the actual management. Now, remember that every prescription related to diet must mention what is the caloric intake, how much should be the protein intake, how much should be the fat intake, the intake of sodium, potassium, fluids, etc. etc. Also, at the same time, we have to advise the patient regarding physical activity depending on presence or absence of comorbidities. Some people they also need behavioral interventions. So, for example, having food on time, having the right quantity of food, having the right type of food, all these things make a big difference as far as the improvement in nutrition status is concerned. So, behavioral interventions are also required. Management of comorbidities like anemia, high blood sugars, increase in blood lipids, and hypertension also is important. Remember that this is a team effort and you have to monitor the nutrition care with the help of other individuals so that you get proper information and you can advise the patient properly. So, regular monitoring of progress over a period of time is also very, very important. So, the medical nutrition therapy is provided by a trained nutritionist or a dietitian, and it is recommended for all patients with chronic kidney disease with or without comorbidities. And if this is done properly, then it would prevent calorie wasting or protein energy malnutrition, as well as it would minimize the impact of other comorbidities on progression of chronic kidney disease. So, medical nutrition therapy can also retard or slow down the progression of chronic kidney disease, thereby doing a great service to the patient because you are postponing dialysis as much as possible. Now, various biochemical and other parameters are also assessed whenever you are discussing the nutrition therapy. So, for example, electrolytes, sodium, hyper or hyponatremia, potassium, hyper or hypokalemia, hypocalcemia, hyperuricemia, hyperphosphatemia, which is related to mineral and bone disorders, chronic anemia, dyslipidemia, chronic inflammation. All these parameters are going to help you for assessing the nutrition status. So generally what we do, we give a low potassium diet in patients with CKD. There are very few patients with CKD who have hyperkalemia, those especially who have chronic tubular interstitial disease. And in that situation, you must remember that the potassium levels have to be monitored. So all of us should know what are the foodstuffs which are high in potassium and those who are low in potassium. So whenever you are advising on a renal diet, then you have to take into consideration the energy expenditure, the electrolytes, water, calcium, phosphorus, and as well as the protein, fat, and the carbohydrate intake. The malnourishment in patients with chronic kidney disease or undernutrition is not very uncommon. Almost 30 to 40% of patients with CKD could be having malnutrition or they could be undernourished. And if there is a presence of protein energy malnutrition or protein calorie wasting, then that will definitely be adding to the increased morbidity and mortality. In a pediatric patient, again, the other parameter which we need to look at is growth retardation. Impaired linear growth is seen whenever a patient has got end stage renal disease and he is on peritoneal or hemodialysis. And the growth retardation is not is seen very frequently in patients of chronic kidney disease, especially who are children. Now, why should a patient of chronic kidney disease develop protein energy wasting? So, the most important cause is, of course, inadequate food intake because of anorexia, altered taste sensation in a patient who has got uremia, emotional distress causing poor nutritional intake, and unpalatable diets can also contribute to protein energy wasting. If a patient has got a superimposed illness, like say for example typhoid fever, then the patient becomes hypercatabolic in that situation, and that is also a contributing factor for protein calorie wasting. If a patient is on chronic maintenance hemodialysis, then the procedure of dialysis itself might add fuel to fire because there are so many water soluble vitamins which are lost, and some amino acids, peptides, proteins, etc. are also lost. So, therefore, there are many causes due to which the CKD patients have protein energy malnutrition. Chronic inflammation is one of the foremost things as far as protein calorie wasting is concerned. The patient could be having progressive anemia because of GI bleed, frequent blood sampling, or blood is clotted in the dialysis process. Also, the other problems which are hidden should be addressed. For example, hyperparathyroidism and hyperglucogonemia. All these things can also be seen commonly in CKD, but they are hidden. Chronic inflammation is one of the most important factors which can induce poor nutrition, and there is a linear risk between high CRP. This particular test was used frequently in COVID patients, and there is a linear risk between the CRP and chronic inflammation and mortality. And remember that serum albumin is also a very strong predictor of mortality. So, those patients who have got a poor serum albumin for a long period of time, that is going to affect the survival of patients with CKD. Low grade chronic inflammation is present in most of the patients who are on dialysis. So, we have to maintain the regular nutrient intake, avoid catabolic state, avoid anorexia, and add supplemental nutrients if required, especially if the patient has got anorexia and poor intake. So, therefore, the wasting of the body can be prevented by giving proper dietary therapy and anticipating which problems can occur during the same. How do you diagnose protein energy wasting? By doing serum albumin, serum prealbumin in dialysis patients, serum cholesterol less than 100, the BMI less than 23, or total body fat percentage less than 10%, and the muscle mass is reduced significantly in patients with protein energy wasting, and if the dietary intake is very very low, so protein intake less than zero point 0.8 grams per kg body weight per day, or intentionally suppose somebody is restricting proteins less than 25 kilocalories per kg per day, again that can lead to protein calorie malnutrition. Serum albumin is a valid and clinically useful measure for diagnosing protein calorie wasting, and this is a measure of visceral protein pool size. If your serum albumin is in the normal range or higher, then the outcomes are also better as compared to those patients who are chronically inflamed, and in that patient the CRP is always high, the serum albumin is low, and that is really going to cause problems in the future as far as the patient's longevity is concerned. Now, down regulation of Rupel-like factor 15, KLF15, is associated with increasing renal fibrosis. Down regulation of KLF15 and renal fibrosis are reversed with dietary protein restriction, especially when keto acids are added. So, to get over this problem of malnutrition, there are medical nutrition supplements and therapies available, which will probably help the patient to avoid protein calorie wasting or protein energy malnutrition. So, KLF15 may play an important role in suppressing renal fibrosis and could contribute to benefits of dietary protein restriction. What is the recommended protein intake? If the GFR is less than 50, that means stage 1 or stage 2, the intake of protein is zero point 0.6 to zero point 0.8 gram per kg body weight per day. If the EGFR is between 20 to 50, then you can advise very low protein controlled diet, zero point 0.3 to 0 gram per kg per day. If the patient has got diabetic nephropathy, then the intake might be more, and in a kidney transplant recipient, the protein intake can be more depending on whether the transplanted kidney is functioning or no. Now, always a patient who is a patient of CKD, chronic kidney disease, who is not on dialysis, only on medications, they should reduce their protein intake because higher protein will lead to higher metabolic acidosis, higher amount of uremia, and the patient will remain symptomatic for a very long period of time. So the protein intake should be restricted to zero point 0.6 to zero point 0.8 gram per kg body weight per day in patients of CKD who are not on dialysis. And also remember that many of these patients, they also have proteinuria, and that proteinuria also needs to be monitored, and the correct dietary therapy needs to be given as far as this problem is concerned. Six selective amino acids, they might become deficient over a period of time whenever there is chronic kidney disease. And if treated, then remember that along with the treatment for hypercholesterolemia, albuminuria, hypophosphatemia, and potentially atherosclerosis, all these complications can be treated partially by giving selective amino acids. So, selective amino acids are glycine, aspartic acid, glutamic acid, glutamine, histidine, and arginine. The daily energy intake recommended is between 30 to 35 kilocalories per kg per day. The energy expenditure on maintenance hemodialysis or on CAPD is same as other individuals. That means lesser restrictions are there. Metabolic balance studies of people undergoing maintenance hemodialysis indicate that a total daily energy intake of about 35 kilocalories per kg per day would suffice. And if a patient is older, then this figure needs to be changed. Also remember that creatinine or EGFR or creatinine clearance can be done or estimated to find out what is the kidney function at this particular time. If the patient has got proteinuria and the kidney function and the serum creatinine is high, then in that situation we can conclude that the kidney function is reducing, and then one has to be really strict about both medical management, that means drug therapy, as well as dialysis. Cholesterol is a valid marker as far as mortality is concerned. Hypercholesterolemia is associated with chronic protein energy deficits and the presence of comorbid conditions including inflammation. So, therefore, always remember that cholesterol can be targeted to a level between 140 to 180. What about protein equivalent of total nitrogen appearance? So PNA or PCR, which is the protein catabolic ratio, is valid and a useful measure of net protein degradation and protein intake in maintenance hemodialysis. When the nitrogen balance, that means amount which is manufactured and amount which is utilized and excreted, when this nitrogen balance is zero, the difference between nitrogen intake and total nitrogen losses is also zero. And because of this unmeasured oxygen losses, nitrogen losses, then PNA provides a valid estimate of protein intake. So PNA is of course protein equivalent of total nitrogen appearance. And the normalization of body weight and other parameters can contribute to the PNA. Again, foods which are high in potassium are mentioned here: avocado, beans, uh, hens, fish, spinach, potato, banana, etc. etc. What about diabetic nephropathy? Remember that excellent glycemic control reduces the risk of chronic kidney disease. So, therefore, if a patient has got diabetic kidney disease in the form of diabetic nephropathy, do not forget to do a cardiac and a eye checkup. Reduce the protein intake as per the recommendation of the nutritionist. And as EGFR decreases with progressive nephropathy, The total dose of antihypertensive medications also needs to be evaluated. Now, blood sugar control and blood pressure control are also two important tools which can contribute to inhibition of the renin-angiotensin system. And then the progression of especially diabetic nephropathy can also be hampered because of poor control of sugars and blood pressure. In patients with type 1 diabetes, control of blood sugar clearly prevents the development of progression of chronic kidney disease. As the renal function declines, the endogenous insulin dose also reduces so that less insulin may be required for a good glycemic control, because all of us know that insulin is metabolized in the kidney. So in patients with kidney disease, the insulin levels are slightly higher, and if that is the reason why the patient can get hypoglycemia. So therefore, please remember that you have to individualize therapy, monitor the sugars appropriately, and then try and get a good result. Hyperkalemia has already been mentioned, the importance of hyperkalemia, but remember that patients can die if the potassium is not controlled. And one of the most important things for control of hyperkalemia, besides drug therapy, is to look at the patient's diet. And the recommended potassium intake is only 2.4 grams per day, depending on the stage of CKD and type of disease. But please remember that hyperkalemia should be treated judiciously, because sometimes you can get severe cardiac side effects because of hyperkalemia. The other factors which also need to be considered in CKD are blood pressure, coexistent medications, what is the stage of CKD, acidosis, hydration, catabolism, etc. etc. So there are many things which we need to consider whenever we are discussing all these issues. Remember that potassium can be hyperkalemia can be treated in various ways by various medications, including the potassium binding resins, and the if the hyperkalemia is troublesome, then of course you can either initiate dialysis or give a more frequent dialysis. We have already mentioned about nutritional assessment and subjective global assessment, which is a sort of a form which needs to be filled depending on what is the clinical status of the patient. Besides that, you have the DEXA scan, which can be done for nutritional assessment. Then adjusted edema-free body weight, that means what is the dry weight of the patient, that also can be used for assessment of nutritional function. Now, how do you manage cardiovascular risk factors in a patient with CKD? Please remember that CKD is equivalent to all other cardiovascular risk factors. So any patient who has CKD will have progressive atherosclerosis, and that is going to cause early death. So one should avoid smoking, keep the recommended diet and take it as advised, keep the weight under control, blood pressure under control, monitor proteinuria, and try and reduce proteinuria with medications and dietary therapy if possible. Treatment of diabetes mellitus, dyslipidemia, anemia, and other drugs like aspirin and antibiotics may be required for these patients to maintain their proper nutrition. So all these parameters need to be considered whenever we are discussing about medical nutrition therapy. What happens in children? So the anthropometric measurements should be used in children more commonly, because you want to find out whether the malnourishment has occurred early. And the commencement of nutritional support in children should start early and do not wait only on the diet, because the patient becomes malnourished, especially children, very quickly over a period of time. So the patients or children who are on dialysis, again, the nutrition requirement is different. In these children also, Please remember that their protein intake should be higher. Same investigations can be done in patients of CKD on dialysis. And you also have to look at the growth of the child if a patient is on medical nutrition therapy and he has got CKD or he is on dialysis. Now, this is a renal diet chart. The caloric intake should be around 2000 and various advices regarding fat content, which should be around 30 grams. The iron should be around 20 grams. Protein intake should be maximized, but the right type of protein, that means those with essential amino acids or so called proteins with high biological value or first class protein, should be maximum. You also have to look at the sodium intake, which should be around 1 to 1.5 grams per day. And you also have to look at the iron and the calcium intake. Remember that the dietary sources of choline, phosphatidylcholine, and L-carnitine, which are in red meat, cheese, egg yolk, etc., are important. And sometimes remember that the uremic toxins, which are normally excreted by the kidney, when the kidneys start failing, they start accumulating the uremic toxins. And the essential nutrients like choline, phosphatidylcholine, and L-carnitine, they are destroyed. And therefore, the CKD patients have got some complications which are related to the progressive atherosclerosis, and therefore, in that situation, also dietary therapy is very, very important. What about medical nutrition therapy? Remember that this is not a single point intervention, it is a long process with regular monitoring and to be done over a period of time with proper supervision, and a goal oriented approach has to be taken because you have to achieve the right goals within the right time frame. So remember that proper nutrition is very, very essential in patients of chronic kidney disease. And if you do not give proper nutrition, then the patient will be having so many problems related to his disease, including physical symptoms, including poor outcome, including earlier death, including the comorbidities which can also progress like hypertension and cardiovascular disease. In CKD patients, it is seen that this problem is often neglected. That means nutrition is often neglected. And what happens is that it's a treatable thing. Malnutrition is a treatable thing, but it is neglected and ultimately you don't get a good result. A proper diet history, nutritional assessment, and counseling are important uh, cornerstones in a patient of CKD who is on medical nutrition therapy. Remember that CKD diet does not mean a restricted diet. It means a proper diet after proper assessment of the physical and the biochemical status of the patient. And in fact, the diet can be made more interesting by the nutritionist by minor variations in our usual diet. So, to summarize, I would give the following message. One is that remember, medical nutrition therapy, that means a dietary intervention, should be considered like a drug. Just as you give tablets to control your blood pressure, to control your blood sugars, and other abnormalities, medical nutrition as a treatment should be considered as a medication. Number two, proper nutritional assessment of the patient is required by a trained clinical nutritionist so that you can find out what is the requirement of the patient. This assessment is done by various ways depending on the various biochemical parameters, the physical examination, the nutrition history, the cultural practices of the patient, the geographical area where the patient is living, etc. etc. The third point, which is very important after nutritional assessment, is the actual physical examination. Make a note of presence of comorbidities, which I have already mentioned. Also note whether the patient has got ideal body weight, what is the age of the patient. So there are so many factors which we need to consider before actually planning the management of medical nutrition therapy. And when you are looking at the management, please remember that your basic data regarding weight, BMI, weight loss or weight gain over a period of time, and all the biochemical parameters should be there in front of you, and then only you can plan the diet. Once you have given the advice to the patient regarding the diet, then of course this has to be followed up rigorously. There should be a proper dietary diary and a dietary recall so that the assessment can be done frequently and proper interventions can be done over a period of time. The principles of management as far as nutrition is concerned are restriction of protein intake to zero point 0.6 to zero point 0.8 gram per kg body weight per day. In dialysis, you give a higher protein intake because there is protein loss. The second important point in actual management is the caloric intake. Around 30 to 35 kilocalories per kg per day should be given. Then you have to look at the fat intake, which should be less than 30 grams. Most of the fat should be polyunsaturated fats and less should be monounsaturated fats. Then coming to the carbohydrate intake, should be around 40% of the total intake. You must supplement the diet with some essential amino acids. So therefore, there are some supplementary nutrition products which are available and they can be used as additional therapy along with the dietary counseling which needs to be done, because many times these patients are malnourished and they need the right mix of proper nutrition supplement as well as the diet of the patient. The other points which are important when you are managing these patients is looking at the calcium, phosphorus, uric acid, so less salt intake if required if the patient is hypertensive, management of infections and inflammation on time. Management of fluid intake is very important because some of these patients they can develop edema because of excessive fluid intake and low urine output, or there could be some fluid overload and the patient can become breathless and go into pulmonary edema. So this is all an intricate matter, and all these things need to be considered whenever you are discussing with the patient regarding the advice regarding nutrition therapy. The next important point is that the nutrition therapy has to be individualized because every patient's requirements are different, biochemical parameters are different, and the physical examination may also be different. So you need to individualize. And the last point is that we are sure that with the right intervention, with the right attitude, and with a positive and cooperative attitude of the patient, we are sure that we will get a good result as far as the reduction in physical signs and symptoms, improvement in biochemical parameters, improvement in the emotional and social structure of the patient, and increasing life to increasing years to life. So that also can happen if the proper nutrition interventions are done over a period of time. Thank you very much for your attention, and I hope that this deliberation has given you some insights into the management of patients with CKD by nutrition therapy.
Uh, Thanks, doctor, for your valuable information. There are few questions asked by our audience. Like I'll share you those questions. You can answer them. Yes, sir. This is the first question. Mr. Ibrahim Ahmed is asking, please guide me on the water intake of patient on dialysis twice in the week. Feels thirsty all time.
So, the water intake on dialysis is very important, and the concept is we have to assess what is the weight gain between two dialysis. So, there is something called as the dry weight of the patient, which is assessed by the doctor and the technician, and there's a target weight which is set. Now, the weight loss is achieved by doing what is called as ultrafiltration or removal of fluid from the body. Every person keeps on drinking water during the day, and the urine output is very poor. So that water gets retained in the body, and in between two dialysis, there is weight gain. If there is excessive weight gain, then the patient starts becoming uncomfortable, and the during dialysis, you need to remove fluid as much as possible. Now, this has to be avoided. So, if a patient has got weight gain which is more than 2 kilos, then again it is a strict no. The water intake should be advised depending on the patient's urine output and the patient's weight gain. So, if a patient is having a good urine output and the weight gain is not very severe, then probably the water intake can be slightly liberal. But if the patient is not passing much urine and if the weight gain is higher, then it should be a very restricted water intake, maybe about half a liter per day. Now, a patient may keep on feeling thirsty all the time. So, in that case, other measures to quench thirst should be employed. And remember that taking a large amount of water, if you are on dialysis, could definitely be detrimental. So, one has to be very careful about this if you are on dialysis. Yes, Subhash? So, the next question is, for dialysis, is only RO water recommended? Yes. So remember that the quality of water on dialysis is very important if you have to get a good result and improve the longevity of the patient on hemodialysis. So dialysis is the process by which dialysate flows in the opposite direction to that of blood, and lot of exchange of material takes place between the dialysate and the blood. So, if the water is contaminated, then bacteria can enter the blood system. Similarly, if the water is very hard and has got a very high mineral content, again that can seep through into the blood over a long period of time, and that can definitely affect the health of the patient. Plus, infection can set in and the patient can go into septicemia. So, proper water quality has to be maintained, and that can be done only by proper techniques like RO, which is reverse osmosis. So, therefore, it is definitely said that you need a RO water to do dialysis. Now, as far as drinking is concerned, of course, the water has to be a potable water. It can be a RO water along with boiling to get rid of the bacterial impurities. But remember that the water quality should be very good for both dialysis and for drinking. Yes, Subhash. What is the water intake in patients with CKD stage 3? Now remember that it entirely depends on the patient's clinical status and the original disease. If a patient has got CKD stage 3, it means that the patient may or may not have swelling all over the body. The patient's water intake can be according to the what is the ideal body weight of the patient, what is the urine output, what is the blood pressure, and what are the other comorbid conditions which will affect the kidney function. So therefore, in CKD stage 3, always measure the urine output. If there is no swelling of the face or puffiness of the feet or swelling all over the body, then you can restrict your salt and protein intake in stage 3, and the fluid intake. If the patient has got no edema, then the fluid intake should be equal to urine output so that you don't get dehydrated. Next question. For dialysis patients, can I go for OTC over the counter brand as a nutrition supplement? The OTC brands, if you use and a patient just goes to the chemist, then there is a problem because the therapy has to be individualized. So remember that there are a lot of nutrition supplements which are available in the market, but the nutrition prescription has to be given by a trained nutritionist or the medical doctor. And why this is important? Because the therapy is individualized, the protein intake is different, the electrolyte intake is also different. So you need different nutrition supplements for a different group of patients. So therefore, please remember that ideally this should be given only by prescription and not as an OTC. Next question. How to limit fluid intake as we take lot of medicine, supplement, etc. other than food. So this is a very thorny issue as far as how to limit the fluid intake. What we advise is that avoid beverages, that means tea, coffee, cold drinks should be avoided. Your water intake quota has to be limited, and you have to plan your water intake according to the number of meals which you take. So, for example, if you are taking 4 meals per day, then plan the water intake in such a way that all the meals are covered, but at the same time, the total amount of water which is swallowed is definitely less, or it is as per the prescription or the advice by the doctor. Yes, Sachin. Next question. Is it possible to fulfill patient's dietary requirement by home cooked food only? Now, in a patient with CKD, we do advise them regarding what are the dietary modifications which are required at home and how should they cook their food, how should they what should be the caloric intake, the amount of food intake, how many chapatis, how much rice, how much dal. All that has been prescribed and advised to the patient. But remember that what happens is that these patients have got a lot of symptoms. They are chronically inflamed, they have a lot of nausea, vomiting, etc. etc. So, in general, what we have seen is that the dietary advice which is given is cannot be followed to its fullest at home. So partially your patients do follow it, but then what happens is that the protein calorie wasting starts and protein energy malnutrition comes into vogue. If you want to prevent that, then ideally the home food can be supplemented by the oral nutrition therapy. And according to me, it is very important to use these supplements for the simple reason that your goals can be achieved properly, much earlier, and scientifically. As compared to that, the home food can be slightly arbitrary, though it can be taken with the dietitian's advice. So, the home food should be and can be supplemented by some supplements, dietary supplements, so that the nutrition therapy is complete and you take care of all the possible deficiencies which can occur because of chronic kidney disease. Yes, Subhash, next question. Which are the good sources of protein for CKD? If any patient is not taking proper food, then should he take protein supplements which are available in the market? I already answered this question partially, but a good source of protein is a whey protein. So therefore, remember that the proper nutrition supplements are available in the market, and if the patient is not able to consume home food properly or the intake is poor and you want to give a proper protein intake in a shorter period of time and with a shorter quantity of fluid, then in that case the protein supplements which need to be taken to prevent protein calorie malnutrition and to achieve your nutrition goals. Subhash, next question.
Yeah. Yeah, thanks, sir. So that was the I think last question which I can see, but one more question is emerged. So
Can
for the
kidney failure be reverted? So, this is like asking a question, can diabetes be reversed? So remember that diabetes is a genetic disease, it cannot be reversed at present. But remember that in patients with chronic kidney disease, the reversal is not possible, but control of the progression of chronic kidney disease is definitely possible. But if it is acute kidney injury, that means the patient has been suffering from a kidney disease which is sudden in onset. He did not have any pre-existing kidney disease, and it is due to some illness which can be treated, and the kidney disease can be reversed. So, in patients with acute kidney injury, there are chances that the kidney failure can be reversed. But if a patient is diagnosed to have chronic kidney disease, which I already mentioned in my talk right in the beginning, that if the patient has got symptomatic kidney failure for more than 3 months, then that should be diagnosed as chronic kidney disease. That certainly cannot be reversed, but AKI or acute kidney injury we may be able to reverse that. Yes, Subhash.
Yes, sir. I think that was the last question. So thanks for a valuable talk and answering all the questions. If any future questions I can see in chat box, I will revert to you, sir. So by the time, sir, thanks a lot for a beautiful talk on the diet in CKD. On behalf of Dr. Reddy's team.
Thank you, Subhash and Dr. Eddies, for arranging this. And I hope that this particular information and this particular session was useful for each and every person who had logged in. And if there are any questions in the future, then I would be happy to answer them.
Thank you, sir. Good day, sir.
Thank you. Bye bye.